Good afternoon. Welcome to this edition of Genetic Alliance webinars. Today we have cancer risk assessment and screening tools. It's actually a good follow-up to last week's webinar on family health history collection tools. If you joined us then, you know that the conversation was moving us and priming us for this webinar today. We have with us three speakers today. Cecilia Bellcross is on faculty in the Department of Human Genetics at Emory University School of Medicine. Her areas of interest and expertise include hereditary cancer and translational genomics. Next up, we have Kevin Hughes, who is the Surgical Director of the Breast and Ovarian Cancer Genetics and Risk Assessment Program at Massachusetts General Hospital. In addition to his work on breast cancer, he is actively involved in the development of electronic health records and standards. And finally, we have Wendy Cohn, Associate Professor in the Department of Public Health Science at the University of Virginia, who has expertise in the development and evaluation of tools for clinical care and public health. Before I turn it over to them, I just have a couple of reminders for our participants. All participants are muted, but that doesn't mean we don't want your participation. So if you have a question, please feel free at any time to type it into the right hand. There should be a panel on the right side of your screen. Type in the questions, and I will field them for our presenters. Usually we'll have all three speak and then do a general Q&A at the end, but if you do have any questions for specific presenters, we can take a couple in between. So with that, I will turn it over to our first speaker, Cecilia.
Okay, thank you everybody. It's a pleasure to be here. I'm going to give a little bit of introduction regarding cancer risk assessment tools and also screens, give a variety of examples, and then illustrate a screening tool that I developed. So when we think about the huge number of tools out there, we have to figure out, is that tool for the situation we need it for? So are we looking to determine if an individual is at risk for hereditary cancer or their likelihood to carry a hereditary cancer gene mutation? Or are we more interested in more general cancer risk assessment and not so worried about the hereditary component? Do we want a tool that is a quick, simple screen to identify individuals who should be referred on for more in-depth assessment? Or are we wanting a tool that actually does provide that detailed risk assessment that we might use to consider alternative screening or management or genetic testing? And of course, what is the condition that you're interested in? If it's cancer, are you only interested in one type of cancer or several types of cancer, or in the case of broad family history, multiple diseases? Each tool needs to be evaluated in terms of its previous validation. Some tools out there have undergone significant evaluative studies, others have not. And in those tools that have undergone evaluation, what do we know about their ability to determine who will and will not get the disease, so their discriminatory accuracy, or what is their accuracy in terms of predicting who may or may not carry a gene mutation? And then is this a tool that is specifically for a trained healthcare provider to use, which means it might be more complicated, or is it something simple or easy enough for the consumer themselves? And then finally, is this a tool that's accessible primarily through the web? Is it integrated into a health medical records electronic system? And there are some occasions where you need to be using a good old-fashioned paper and pencil tool, depending on the situation. So I'm just going to go through some classic examples of tools, in part to illustrate the variability and the pros and cons. CancerGene, also known originally as BRCA Pro, has been around a long time and gone through several updates. Specifically with respect to breast and ovarian cancer, it calculates likelihood for BRCA1 and 2 mutation probabilities and also provides, as you can see on the right, age-adjusted risks for breast and ovarian cancer over time based on that mutation probability. It's relatively easy to use and easy to access. It's updated regularly and has undergone multiple evaluations. I give a couple references there for some of the validation studies. It does adjust for tumor pathology, previous oophorectomy, and actually the program Cancer Gene can also assess for other forms of hereditary cancer syndromes. But it does have some limitations, as you can see here, and each model will have some limitations and might be useful in some circumstances and not others. Another comprehensive model out there focusing on breast and ovarian cancer is Boadicea. And again, you see the references and the website where it can be accessed. Again, what you have from Boadicea is a calculation of BRCA mutation likelihoods and age-adjusted risk over time. The benefits of this particular model is it looks at not only BRCA1 and 2, but other potential genetic effects. And you can insert very, very detailed family history, also just for cohort effects, and unlike BRCA Pro, does include pancreatic and prostate cancer in the calculation, and as well provides specific risk for contralateral breast cancer and ovarian cancer in individuals with a previous history of breast disease or breast cancer. But it doesn't account for non-genetic factors or previous pathology, race, and it is a more complicated model to use that might be more appropriate for those providing in-depth risk assessment. A third model, IBIS, or the Tyrer-Cuzick model, again you see the reference and the website availability here, actually is the only one that really combines both non-genetic risk elements as well as genetic risk elements and provides an output as you see here. It is relatively easy to enter data, but you do need a lot of family history details. But it hasn't been as well validated, and it does have some model assumptions that may or may not be appropriate. And in using this model, I found that it tends to underestimate risk in women with very strong histories and overestimate risk in women with less strong histories. In particular, women with a history of atypia and a positive family history are often given risk higher than BRCA mutation carriers. Probably the most well-known model out there is the GALE model. That's been around for quite some time. It's used quite broadly by clinicians, and it can be a very good model, particularly for population-based studies. Unfortunately, it's not very good at identifying women with hereditary cancer risks because it does not include second-degree relatives or age of diagnosis. It does increase risk substantially for benign breast biopsy, which may or may not be appropriate. And it's been demonstrated on an individual basis to not provide very high accuracy of individual risk prediction. The Klaus model was one of the earliest genetic models, even appearing before we have identified BRCA1 and 2. It does provide some opportunity for empiric risk estimates, but has some limitations as well, as you can see here. The next two slides are just to give you an example of some of the variability that you might get from these different models. So you can see the pedigree here as well as the health history information. And you see a wide range of risk provided by the different models. So again, it's important to understand that not all models are going to be appropriate for all risk situations, and potentially using more than one model to assess risk and considering the pros and cons of those models is important. Here you see the actual BRCA and Pro and Boadicea. The two models, BRCA Pro and Boadicea, do have very consistent results. You see some difference with IBIS. Here's a less significant family history, and yet the GALE model gives it a very high risk on the basis of benign breast biopsies, whereas the other models are less significant. And we see it has a relatively low likelihood of a BRCA mutation being involved. Just to keep in mind, though, I focused primarily on breast and ovarian cancer risk models. There are multiple models out there for other hereditary cancer conditions, particularly Lynch syndrome or HMPCC, and this is one of the models. There are other colon cancer risk models out there too, one available through the NCI where the GALE model is also available. But again, what you see here, it's not appropriate in terms of identifying hereditary cancer syndrome. Lots of other tools and resources, which we don't have time to go into, of course, but this list is accessible off the Genetic Alliance website if you're interested in exploring these further. And I'm just going to take a couple of minutes to illustrate a screening tool that I developed and validated a few years back. Let me see if I can get this to work. Okay, so this is called the Breast Cancer Genetics Referral Screening Tool, and really the idea behind this is to quickly and easily identify individuals who should be referred for cancer risk assessment and genetic counseling because of the possibility of BRCA involvement. It can be accessed by either healthcare providers, where there's more detail about the tool and references, or as well consumers, which gives simpler background information. This is just terms of use. And here you see the tool here. There's a series of 8 questions, and depending on how the questions are answered, might prompt more detail. So here the individual says there is some breast cancer under 50 in their family, and then it gives them the opportunity to indicate who that person might be, either on their mother or their father's side. And just to get through this quickly, so you can see it's something that could be done in a doctor's office by a nurse practitioner, a nursing assistant, and only takes a couple of minutes. And then provides a risk assessment. In this case, I entered it so it would be a positive screen. And then there's links to multiple resources here, as well as the ability for a printable summary that also has links to resources, and provides something that the patient can print out that summarizes the information they entered and their results. The tool was validated. Screens were performed on about 3,000 women undergoing mammography, and then a subset of about 300 individuals at 3 levels of risk had a detailed pedigree assessment and analysis with some of the more in-depth models that I indicated. And the web tool has a discriminatory accuracy of identifying women at 5 to 10% or greater likelihood for BRCA mutation in the range of about 0.9 or 90%. So I'll end there and turn it over to the next speaker.
So this is Kevin Hughes. I assume I'm up for speaking, and I think Tam is going to convert the screen to me. I'll be following up on what Cecilia has had to say. Cecilia has been talking about the various models that are available. What I want to show today is what we have in terms of what we can do for the practitioner who's taking care of these patients who are identified by the screen. So you can think about these models in 2 different ways. The first set of models or first set of tools would help to identify patients in a general way in a mammography or primary care office. The next set of tools will be used by the geneticist or the physician taking care of a patient at high risk, and therefore provides much more detailed information about the patient and gets a much more granular set of data. So the tool we're showing here is called Hughes Risk Apps. The senior programmer I was working with, or still work with, is Sherwood Hughes, who's not a relative, so we call it Hughes Risk Apps. We both get credit for it. And for this, we see a patient here is going to be seen, again, by a physician or nurse practitioner or genetic counselor. And we open up the risk clinic screen, which shows you what most tools at this level would do. You would need to put in the names of the relatives, the ages of the relatives, their vital status, and what diseases those relatives have, and then put in additional relatives as well. This can be very time-consuming, so we approach that in 2 ways. One is to use a tablet PC to let patients enter their own data. And the second is to use interoperability. We can import data from the Surgeon General's website, which is called My Family Health Portrait, or from other HL7 compliant software. So if the patient has already done a tool where she's put in her own family history, we can then access that message and pull that data directly into this tool without having to retype it. And when you hear about interoperability with the new electronic health records, this is what interoperability is, the ability to pull data from one software package to another. When you do that, you can look at a pedigree based on the information, again, that the patient has put in, so no major work by the clinician or staff. And you can add additional risk factor information that may also be important. And as Cecilia had talked about, for a Gale model, you'd need the number of pregnancies, the number of biopsies. For BRCA Pro, or for BRCA Pro specifically, you need to know if the patient is Jewish or not. BRCA Pro and Gale both look at the race of the patient. Gale requires the age of the first period, and we'll put in smoking information as well. So this tool is really built as an interface to allow the clinician to not just help the patient get the data in more efficiently, but also to run the various risk models. So this will run BRCA Pro, Klaus, Gale, and the Myriad model, and also run the colorectal models, MMR Pro and PREM. And essentially, if a model is available in an open sort of way, we can bring in any model into the system that's out there. So we have not created our own models, but worked with the modelers to bring this into the system. What you then see here is a display that's meant to help the counselor know what to do next. It shows the pedigree, and most of you here are familiar with this, circles being women, squares being men, cutouts being cancer. It shows here the chance of this patient, your patient who's marked by the arrow, of having a BRCA1 or 2 mutation, which is 37%. But we also run BRCA Pro on every other family member. So you can see the distribution of risk within the family. And you can see that that risk is coming from the maternal side rather than the paternal side. Using clinical decision support, the software also makes a recommendation. We suggest testing a relative. We'd like to test the person who's had cancer, is at the highest risk of mutation, as the first person we test. And the software then tells you which relatives to test in order of likelihood of mutation. So the sister here is at highest risk of mutation, so we'll say that she's willing to be tested. And we can then also identify that sister here and add additional details and say that she lives in Orlando. If I can spell that correctly. Orlando, and Florida. So if we have to do testing, that would have to be done in the Orlando area. So here on this page, we show the level of risk for the individuals, the recommendation relative to genetic testing. The second thing BRCA Pro shows us, as Cecilia had brought up, is the risk of breast cancer over time. And for this patient, that's shown here by the black line, that her lifetime risk of breast cancer is 28%, and her risk of mutation is 37%. We also show recommendations of what to do relative to MRI, mammography, chemoprevention, and why we make recommendations of that type. But the counselor wants to know not just what's the patient's current risk, but how will that risk change if they test positive or if they test negative, and how does that compare to the green line, the average population. And for each of these situations, we make a recommendation as to what type of management that patient should have. We do the same thing for ovarian cancer here, showing the risk with the BRCA1 positive in the red line, but can also look at what would happen if this patient were BRCA2 positive, which has a lower risk of ovarian cancer than BRCA1. So we show here the risk of mutation and also the lifetime risk. We also show the Gale model calculation, showing the Gale calculation versus the general population, the Klaus risk of breast cancer compared to the general population, and the Myriad tables, where we then pick out which box this patient would fall into, and her risk of mutation by Myriad is 7%. So while it's 37% by BRCA Pro, it's only about 7% by Myriad, again highlighting the differences between these models and why some are better in certain circumstances than others. We are now moving toward doing the same thing for colorectal cancer. This is showing the results of MMR Pro. MMR Pro is also written by Giovanni Parmigiani, who wrote BRCA Pro, and this is the colon equivalent. We have MMR Pro built in. We have not begun to work on the clinician decisions or relatives to test as of yet, so that's being built. And our third tab here is what we call our All Syndromes Known to Man tab. And with this, we try to look at what other syndromes the counselor should be thinking about. So these are all syndromes where cancers from that syndrome appear within this family history. So for Li-Fraumeni, it shows you which patients have Li-Fraumeni-type manifestations, and also tells you what else would be in Li-Fraumeni besides the manifestations you're seeing here. If you click on this info button, it will bring up a web page that tells you about Li-Fraumeni. This is the OMIM homepage from the National Library of Medicine. Or if you click on the second button, the gene test page, that will bring up gene tests, which tells you where to get genetic testing done for Li-Fraumeni syndrome. So trying to help the clinician not just think about BRCA1 or 2, but also about other syndromes that might be important in this particular patient family. From there, we then make recommendations as to what we should do for that individual based on their current level of risk. We make recommendations relative to the breast, make recommendations relative to the ovaries as well. And then from that point on, the software then will generate the paperwork required of the clinician. It generates a letter to the relative who we'd like to get tested, and generates a letter to the primary physician. We're working on a patient letter as well, but we're not far enough along in that to really demo that at this point. So what this will do is then generate the paperwork that the genetic counselor or nurse practitioner would have had to do otherwise, trying to make that easier, an easier thing to accomplish, therefore decreasing her workload and making her able to see more people within the same period of time. So again, trying to increase efficiency while simultaneously collecting good granular data for future research. So for the letters that goes out to the clinician, it gives the family history as a table, explains that what we've done within the course of the visit, why we think this might be a hereditary family. We've counseled her about the elements of informed consent relative to genetic testing, explains why we want to test a relative as opposed to testing the patient herself, says what to do for the breast, what to do relative to the ovaries, puts all the recommendations as bullet points so they're easy enough to follow, and goes on to CC the referring docs. In addition to that, we have a letter available for the patient's relative. We cannot send this letter. This relative is not our patient. But what we can do is hand this letter to the patient, explain to her that her relative is the right person to test, and then she can give this letter to her relative to help her relative understand why we think she should be tested. Again, it explains why we think this might be a BRCA1 or 2 mutation, why this relative is the right person to test, and also gives the genetic testing centers in the Orlando area where she can go to for her testing, so it makes it easier for her to comply with that recommendation. So the point of the software is to get better data going into our databases so we better understand hereditary disease going forward, but simultaneously to make the work of the clinician easier in terms of dealing with these patients so they can be more efficient and give a higher quality of care, or at least that certainly is our goal. We can also, within this context, look at the pedigree again and interact with that pedigree. We can say now that Janet has had testing. When we look at testing, you'll see that we're picking a breast ovarian panel, and that then gives us the various breast ovarian genetic tests that are available. On the other hand, if this patient needed cardiac genetic testing, it would show you the cardiac panels that are available. So we've tried to design the software to not just deal with breast ovarian, but to deal with any genetic testing or any type of hereditary disease that might occur. If we choose BRCA1 or 2 testing, and once we get the result back, we can then add that in by just beginning to type the mutation, and then it pulls that up from a database as that we currently have. Now, if you look at this, the fact that a genetic testing company will send me back a result on paper that I then have to type into a computer is not an example of interoperability. So the future of this will be where we can send our family history information to the company doing the testing with a requisition asking for a test, and that they send that test back in electronic format that can be pulled directly into our system without having to retype it. So I think the future has to do with the beginnings of better interoperability across systems and the beginnings of using these systems both externally as we're using it now, but eventually integrating this into the electronic health record, which currently does not really manage family history very well, can't draw pedigrees, and doesn't really handle genetic test results. So on that note, I will stop and pass the controls off to the next person.
Thanks, Kevin. Next up, we have Wendy Cohn.
Thanks. I'm going to ask you all to zoom out a little in your thinking. Can you see my screen?
Yes.
Thank you. I think Cecilia and Kevin both pointed out some things that are really important to consider as I'm speaking. So one is that some of the models that we have are good for certain circumstances and not for others. And also the word interoperability is key here so that we can decrease the amount of times that either patients or clinicians have to enter the same information. And that's something that we're still working on. I'm going to tell you about a tool that we started working on about 10 years ago called Health Heritage. And we started it to help patients gather their family health history and manage it and understand what risks they might have because of it. This was in response to kind of the way that cancer genetic counseling at that time and still is to a certain point conducted. And it's time-consuming and very labor-intensive. And in 2000, we thought this was not going to be a sustainable future for genetic risk assessment. So we took a wide approach, and we didn't just focus on cancer. We started with 5 different disease areas that included cancer, but there was also neurologic diseases, cardiac diseases, and a few others. And we assessed risk for 89 conditions. We didn't put this in a high-risk setting. This was freestanding. It was developed so that it was easy for patients to collect their own family health history. And all of the information was entered by a patient. And after a patient would complete Health Heritage, their primary care physician would be able to access both the pedigree and the risk recommendations if the patient had given them permission. So we really developed something to be outside of a formal system of care while recognizing that we wanted to ultimately bring it back into a system of care. And our thinking is really this is going to start moving to primary care. So like a lot of these tools, we had 3 main sections. The first one is to help people create their family tree, and we used at that time 1st and 2nd degree relatives, although that's now changed to include 3rd degree. For each relative, we asked people to follow a set of branching logic questions to answer health history information or fill in health history information about these conditions in 5 disease areas. And then we had risk algorithms running in the background to assess whether or not they might be at increased risk for any of these conditions and provide some risk management recommendations. And when we first did this, this was at a time where there really weren't all of the models that Cecilia and Kevin talked about. Most of those didn't exist. A few of them did, but there's certainly more now. And so it took us about 2.5 years to develop Health Heritage. There were a lot of different disciplines represented. We did a really intense needs assessment to understand what patients wanted, what primary care physicians wanted, what genetic counselors wanted, what geneticists wanted. And we developed our process for deciding, how to pick different conditions in these disease areas, how to go about computing the risk, and especially when there was not a lot to guide us. And we focused a lot on security. Our security at that time was state-of-the-art because people were certainly reasonably concerned about putting their family health history information onto a web-based system. We also spent a lot of time designing our user interface. Even before we did Health Heritage, we recognized that this was going to be a bit of a burden to people to, gather and then track their family health history, so we wanted it to be as easy as possible. But, in the back of our minds, or maybe even in the front of our minds, we wanted to take the standpoint that, once you do this, once you develop your health heritage record, updating it is not as hard, and then you can use it when you go see any provider. My training is in evaluation research, and so we developed a very detailed evaluation of health heritage when we first developed it. We did some, pretty standard web tool evaluations, like heuristic evaluations, where you look at your website, comparing them to a set of standards. We did think aloud interviews where we asked potential users, both patients and clinicians, to do certain tasks on the system, and we asked them to think out loud as they did those tasks so that we could identify any problems that they were having. And we also did a pretty significant pilot test where we compared health heritage and usual care, so just a primary care office. We compared those two to what we consider to be the gold standard in terms of family history gathering and interpreting, and that would be a genetic counselor and a genetic specialty team. And health heritage was probably not to any of your surprise, it was a significant improvement over usual care, and it performed well compared to genetic counselors in terms of how many relationships and ages and conditions it identified. And we've actually pretty recently finally published this. If anyone's interested, I can get you the reference. We also did a user satisfaction survey. I pulled out two things here to show you. One is that 54% of the people reported it wasn't at all difficult to complete. Well, that means that just about half of them thought it was difficult, and that's something I want you to keep in mind as I tell you what we're working on now. And about half of the people also thought it was difficult to find health history information, and that's something I'm sure that resonates with a lot of you, whether you're providers or patients. And these are things that we set out to address in our new version. So I'm just going to show you a few screenshots. This is our old health heritage version, and there will be some things that will be the same and some that will change, but just to give you an idea of how we had it set up. On this page, there were really three main things you could do. One is you could create your tree, so that's in the purple. In the green, you could add your family's health history. And in the gold, you could view your recommendations based on your health heritage. And so to develop your tree, we would ask you to identify who's in your family, and we had a short list of questions or information that you had to complete to identify who was in your family. So the name, what relation they were to you, and their age, current age or birth date, and age at death if appropriate. We developed a pedigree, and this, when it was fully functional, had a number of icons that you could quickly see how many cancers there were in your family, how many heart issues there were in your family. And then, as I mentioned, we had branching logic questions, so you might have a certain set of screening questions. So if you said that no one in your family had cancer, you weren't going to be asked any other cancer questions. This is an example where they have some follow-up questions that are kind of vascular in nature. And we tried to tell people, what was in front of them, so how many questions they were going to have to answer, and that was dynamically generated based on their previous answers. This is actually an example of some of the neurologic questions. If we're asking about a certain relative, we might say, did this relative ever have convulsions, seizures, or staring spells? And then on the right side, and this is something we learned in user testing, we gave people 4 different choices. So they could either say, yes, I know that, no, I didn't, or I don't know, and I'm never going to know. So say they're not alive, or I don't talk to them, or it didn't matter the reason. Or I don't know, and I can find out. And so that became kind of a placeholder for people that they could then come back to. We did this a long time ago, and at that point there wasn't a ton of interest in family health history and kind of the resulting risk assessment, and that's definitely changed over the years. And so our new project is to expand health heritage. We have funding from the NCI, so we're really focused on cancer right now, to update our clinical decision support, so all the algorithms that run the risk, to incorporate genomic data into the risk assessment and our risk management recommendations, and to integrate health heritage with an electronic medical record. And we're starting with Epic, although we'll move on to others in the future. And this speaks to, the whole piece of interoperability that, we don't want to continue to collect information multiple times. It decreases its quality, and it's just hard to do. And this is one of the things that we learned doing our first health heritage study, that it was really hard for people to collect that information. So we're trying to make it easier. These are the cancers and the syndromes that we are including, or there are a few that are probably going to get taken off this list just because we might run out of time, but this is the range of cancers. I'm going to tell you a little bit about our general approach, and then I'll give you some examples. So really there are two main areas in our approach. The first one is to develop evidence-based rules for risk assessment, and then the second is to provide recommendations that are personalized for someone's risk to patients and their providers for risk management. And I'm going to tell you a little bit more about that. So evaluating the evidence, we decided that we'd really like to use something that exists if possible, and so we have decided to use the National Comprehensive Cancer Network guidelines, NCCN guidelines, as our foundation when they're available. We supplement that with an iterative search strategy that looks for things like meta-analyses and systematic reviews first, guidelines, and then certainly we consider some high-quality individual studies. And then we've developed this relational database to classify our literature by the type of cancer, the type of syndrome, because we really needed to keep track of it in a better way. And my computer is stuck. There we go. Okay, so this is, the top it looks a little cut off, but this is actually our pancreatic cancer risk assessment literature database. And so you see we classify on the very left the type. So these are all happen to be systematic review or meta-analyses, the year, the author, the title. And then we have the general label. So our risk assessment is not just looking at things that are hereditary or familiar. We're also looking at some of the personal risk factors as well. So you can see here that we have things related to physical activity or BMI or alcohol or Poit-Jaeger syndrome, so however we've classified it. And then the relevant identifiers. And then over on the right is our action. So for some articles, usually systematic reviews or meta-analyses, we will read the whole thing carefully, whoever's working on that tree, that decision tree. And for some, we'll abstract them so that we can pick and choose wisely, and we're not reading tons and tons of things. I'm not sure why this keeps freezing up. I can get it to go. There we go. So as you can imagine, there's some challenges in reviewing the evidence so that we can come up with these risk rules. The first one is that while the NCCN guidelines are fantastic and really well developed, they're not that user-friendly in terms of writing rules based on them, and so that's been a little bit tricky. And it's also hard to distinguish sometimes whether or not we are developing criteria so that someone would get additional risk evaluation or criteria for specific genetic testing. So we've been teasing those things out. The other tricky thing is, are we looking at someone's risk for a particular cancer, like breast cancer, colorectal cancer, or are we evaluating the evidence for the risk for a specific syndrome? Another challenge is just the sheer volume of evidence that we're reviewing, just the number of cancers and syndromes that we've chosen, and the different professional societies that have a stake in what we're doing. And then, of course, there are a few things that do conflict. So generating decision support trees, whoops. So as I said, we examine the systematic reviews in their entirety and then review the abstracts. Our decision tree structure will begin with targeting a specific risk for a specific cancer and starts at the top with risk of carrying a deleterious mutation, so for example, BRCA1 or 2, and then moves on to other familial risk, then to cancer-specific risk factors, and then finally other factors associated with risk, and this could be something like alcohol consumption. This is an example. This is the top of our colorectal decision support tree. So if you look on the very top, A, diamond A, this is a decision diamond, and this looks at some of the mutations that might be in someone's family, a family history of a deleterious mutation. And then they work their way through, or we would run them through this as a set of rules, all the way down to the end, which would dump them out at a population risk. So this is just an example of the top of one of our trees. The other thing that we do is we keep tree narratives, and these are just some examples of what we have in the narrative. So as we're developing the tree, we're recording all of our decisions, and then at the bottom you can see as we modify things, we note what the modification was and what the date, and sometimes we'll actually have a reference. Just quickly about the genomic information, while we really we think it's important to start including some of this in our risk assessments, it's likely a little too early to actually incorporate it. So what we're doing to handle that is we have a watch list of genomic data or genomic testing that we think is getting close, and at a minimum you can record that. So if someone went off and did personal genomic testing, you could record that in Health Heritage at this point, but it really won't impact your risk today. For our approach for developing risk management recommendations, we have a similar process with the evidence, and we're also still starting with NCCN guidelines where they're available. Our team that develops these recommendations includes genetic counselors, disease-specific genetic specialists, and also primary care providers. And each risk assessment, what we call OVAL, on our decision trees will generate a set of risk management recommendations. I have an example, I believe, for you. So these are just pulled out of order, but just to show you an example. So on the left side, and this is in colorectal cancer, on the left side, that decision diamond is a personal history of more than 100 adenomatous polyps. And if the person had gotten through the tree and ended up with yes, then their risk oval, that number 4 there, would put them at increased risk for colorectal cancer. And these are our notations, because of this personal history of more than 100 adenomatous polyps. And then over on the right, I just wanted to give you an example of kind of what the bottom line is, and here we have an NCCN bottom line of what to do about that. The next row, I, the decision I, first-degree relative with certain syndromes might put you at potential increased risk for colorectal cancer, decision oval number 9. This is one where we might recommend testing to determine whether or not they're actually at increased risk for colorectal cancer. And then if you go down to diamond W, this might confer some increased risk for colorectal cancer, and there's some specific guidelines for the patient or the primary care doc that will follow that. And then the green, number 33, is your population risk, and we'll include the appropriate guidelines. And the last thing I'll tell you about is kind of the link to the electronic medical record. This is just a kind of high-level flow diagram. So right now we're working with Epic, and if you have Epic's electronic medical record, Health Heritage will be able to pull certain aspects of your medical, surgical, and family history into Health Heritage and populate your Health Heritage record for you. And then after you've completed everything else that you need to complete, and ultimately we hope to be including electronic connection with family members as well. And after your Health Heritage is run, then a result is sent back to your primary care doc that has your risk, your recommendations, and your pedigree. And we're in the thick of development right now, so hopefully I'll be able to show you something next time.
Thank you very much to all three of our speakers. I'd like to apologize if you hear any background noise. We are in the midst of a fire drill here at Genetic Alliance, a little bit of bad timing, so I apologize for that. But just a reminder to all the participants to please type in your questions in the panel on the right side of your screen. We have a few to get us started, but keep them rolling in. Bring up the question list. So the first question, which I think might be for Kevin, and to participants, no apologies necessary, but the question says, forgive the ignorance of this question, but why test the relative instead of the patient?
Oh, very good question. So when you're looking at a BRCA1 or 2 gene mutations, those mutations can occur anywhere along over 2,000 base pairs. So you need to do what's called full gene sequencing. When you do full gene sequencing, if you identify the family-specific mutation, you can then go ahead and test other family members for that mutation. The full gene sequencing costs about $3,500, whereas the family mutation costs about $500. So when you're doing the full gene sequencing, in the ideal world, you want to test the person most likely to have the family-specific mutation, and that's someone who already has cancer. So in a family where there are living relatives who have had cancer and are at risk of having a mutation, that's the ideal person to test first. If those folks are not available, then you can always test the patient. But if you test her and she tests negative, you don't know whether that means that she does not have a mutation or whether it means that there's another mutation in the family that you weren't aware of and she may have that mutation. So you really want to know what the family mutation is.
Thank you. Our next question is for Wendy. It says, my impression has been that colonoscopy is recommended for everyone over 50 at 10-year intervals, but your presentation indicates otherwise. What is the bottom line?
I am probably not the best person to answer that question. I think there is, and Kevin or Cecilia, if you guys know, please jump in, but I think there is some depending on which set of guidelines if you have a primary care doc that views one set of guidelines versus another as being more important, there is some variation. And if you're at higher risk, there's certainly a different screening regimen that might be offered to you.
This is Cecilia. Yes, that's absolutely true. In general, colonoscopy every 10 years beginning at age 50 for individuals who are at average population risk. For families with a hereditary level of risk, age of onset somewhere between 20 and 25, and colonoscopies every 1 to 2 years, whereas somebody who has a more moderate risk, for example, a father with colon cancer at 60 and nothing else, might be screened every 5 years. But there certainly is some variability depending upon the provider and the guidelines utilized.
Any thoughts on that, or should we move on?
No, it's good.
Okay, great. This is for both Kevin and Cecilia. How widely have your tools been implemented, and what are your next steps?
I'll go first, if that's okay. Our system is available on the internet. It's available for free. Anybody can download it and use it. We have about 130 known sites using the system so far. Our goal is to have every risk clinic in the world using it, but that may take us a few years.
In terms of my tool, I think it's been mostly accessed by individuals. I don't have the same level of backup support or funding, so I haven't been able to monitor it to the same degree. It's hopefully something that a few centers that have expressed interest that are going to look into and do some clinical practical validation studies as well.
Thank you. Our next question, Dr. Hughes mentioned that EHRs are not really ready for family health history integration, but Wendy, I think this is for you. Can you speak at all to the integration with Epic and other EHR vendors?
Yeah, I think what was mentioned is that they're not ready, but more importantly, they don't do a really good job at collecting family history information and documenting it well and collecting it in a standard form so that we can use it in multiple places. So in fact, we're not relying heavily on the family history information that has already been collected in an EPIC medical record because it's very limited. I mean, we will pull it over into Health Heritage, but it really just has a subset of diseases by a subset of relatives, and it's not comprehensive. Certain vendors are more willing and more interested in changing their own data model so that they can receive back family history information, but right now I'd say EPIC isn't one of them. So while we'll kind of further collect and keep in a standard format good health history information, we can't then send it back to populate someone's EPIC medical record, and that's really what needs to happen to make this truly interoperable.
Yeah, and I'll just follow up on that, and part of this is a plea to the audience. The electronic health record vendors are not doing very much with family history currently because they say that no one is asking for it. So if you run into a vendor, tell them you want a family history section, that works. The problems with the EHR family history are multiple. The first is when they do have a family history section, it's very difficult to use, very time-consuming, and most times doctors leave it empty and put their family history into free text where it's not very useful in a note. The second problem is that if you did all the work of putting the information into the family history section, you would get nothing in return. The EHRs are unable to draw a pedigree. They're unable to do decision models or use these models that we use for risk estimation. And they're unable to interoperate. They are not HL7 compliant, which is the international standard for for any electronic health record and for family history as well. So those are the problems with it, and the EHRs have to solve that. AHEC, the American Health Information Community, told or essentially put together the basic elements of a family history data set that every EHR should adopt. That was published in JAMA in 2007, and as of right now, no EHR vendor has yet adopted it. So every chance you get when you run to an EHR vendor at a cocktail party or anywhere else, tell them to get a family history section into the EHR.
We'll do that. We have two, I guess, basically similar questions. Just to restate the URLs where the publicly available tools can be accessed. I think that's because the second question was restate the websites available for databases.
So for Hughes Risk Apps, it's www.hughes, H-U-G-H-E-S, risk, R-I-S-K, apps, A-P-P-S.com. So HughesRiskApps.com, no spaces, and feel free to download the software, and we're happy to help if you need anything.
The breast cancer genetic screening tool, BRCAGEN screen.org or .com. This particular site does not store information, so it's used on a case-by-case basis, but you are able to create a printable, downloadable report to save.
Okay, thank you. Those are all the questions we have. So last minute request, if you have any more questions, please feel free to type them in while we wrap up. But I would like to thank, again, our presenters. Thank you very much for participating today, and for all the people who were here listening and asking questions, thank you for joining us. This webinar was recorded, and it will be available in the resource repository at resourcerepository.org sometime next week. Some people might have been having difficulties downloading the session materials from today. Those will also be available shortly in the resource repository. Sorry for any inconveniences. But other than that, please stay tuned, genetical.org/webinars for our upcoming webinars in the month of December. Next week we'll be on break for the holiday. And so everyone enjoy the Thanksgiving break, and thank you again for being with us.
Thank you, Vaughn. Bye.
for having us.